are here. They are waiting and hungry for what you are going to feed us with today. It's your time now.
Okay, thank you very much, Mr. Planbay. And good evening, colleagues, and sorry for the delay. It's only a problem when it comes to these gadgets. I'm going to share with you the—
Doc, are you there?
Can you hear me?
We can hear you loud and clear.
Oh, okay. I think Mr. Tembe is one who is having problem with his internet. I'm going to share with you the presentation on radiological diagnosis of common fluid liver lesions. It's a topic that I think is important, especially for you guys. When I was thinking of presenting this topic, I was thinking that I'm going to present a topic to people who know more than I do when it comes to a radiological imaging of this lesion. I think straight to go into it is that I managed to select the solid liver lesions because we do have other cystic liver lesions, so that we can just narrow them. And I didn't want to go into all of them or almost all of them because common things are common, and it's better to discuss the one that we see often in our practice. As an introduction, the majority of liver lesions are seen incidentally during imaging. Sometimes patients are presenting with something else, and when you do the imaging, you see the lesions. And I'll tell you that most of patients are scared because once they see something in the liver, they become very worried. And most of these lesions, they don't require surgery. But most importantly, they have to be characterized, because if they are malignant and they are characterized properly, then we can run into trouble in the near future. And now with the imaging that we do have, it's relatively easy to characterize these lesions so that we don't have to operate on our patients. Still, the diagnosis is based on proper history taking and examination, and also some blood investigation, as we'll see as we go on. And as we know, imaging plays a significant role in getting the diagnosis in these patients. The imaging modalities that I'm going to look at here, it will be ultrasound. Ultrasound we can have with Doppler or with contrast, and we can have the triphasic liver CT scan, the MRI, a PET scan, and CT angiogram. I wouldn't touch on them. I'll just look at the above three, because these are the ones that we are used to, that we normally have. And I have to stress that triphasic liver CT scan is very important, and we have to do it properly, where we have to make sure that we have the images, the pre-contrasted, and then we have to have a proper arterial phase, and also the portovenous phase as well, and then the delayed, so that it will help us to make the diagnosis. And most importantly, we also see that there is sometimes an overlap in the diagnosing of these lesions. That's why at times we need to do ultrasound scan and then to do CT. Sometimes we can make a diagnosis on CT, then you have to move on to do a MRI. Sometimes MRI with contrast, especially liver-specific contrast like Bremovist. So the solid liver lesions, I've characterized them, the common ones, the benign lesions, and then the neoplastic lesions. The benign lesions that we have there is the adenoma or hepatocellular adenoma, focal nodular hyperplasia, focal fatty change, or focal fatty infiltration. This one we see most commonly when we do our scans, and it's good that it has got no clinical significance. And then we have the hemangioma. The neoplastic ones, we have hepatocellular carcinoma, the cholangiocarcinoma, and the metastasis. So we'll go straight one by one and look at what we can see. Focal fatty infiltration of fatty liver is less common. You find that there is no mass effect. It is something that we see when we do imaging, but it might be due to the blood flow into the liver, the venous flow into the liver, or the distribution of the fat globulins in the liver. That's why you do get a differential uptake of contrast, resulting in showing us these lesions. As we can see on the ultrasound image, usually they are hypoechoic. There's usually no mass effect, and there's no vessel displacement, meaning that it doesn't act like a mass. As you can say, the mass, it can go through the vessel. You can see the vessel going through it, seeing it above and below the vessel without any mass effect. So it's you commonly see those. They can vary in size from the small ones to the big ones. And on CT scan, we see that you can see that it's a hypodense of low density and with a sharp interface. That's why I said usually it tells us that there is differential uptake of contrast, and it will go with the supply, blood supply of the contrast, like we see here, that is mainly in segment 2 and 3 that you see. If there is no any clinical history or any other disease associated with it, you should be able to see that it's a hypodense lesion. But in case of where there was trauma or there was any surgery done, it might mean that there might have been injury to, for example, the hepatic artery, leading to hypoperfusion during contrast infusion. So that I think is clear. It's an example of that. You can see that we are on the arterial phase there. You can see the artery, and also you can see the IVC as well. And then we move on to the next one, which is adenoma. Adenomas are very rare, and they are usually associated with oral contraceptive pill use. So that's why, as part of history taking, we have to make sure that we tease that one out. And there is a risk of bleeding and also malignant transformation. I won't go more into the details of it, but there are 4 classifications of adenomas, and they differ with the malignant transformation. And you can see that they are more common in females than men, with a ratio of 9:1. And most importantly, the adenomas, when you see them in females, so you look at the size, and if they are more than 5 centimeters, it's always recommended that they get operated because they can change to become malignant. In men, for example, all the time, no matter the size, if the adenomas are seen and diagnosed in men, they should be operated because there is high risk of malignant transformation in males as compared to in females. This is the ultrasound presentation of the adenomas. I think when we see these pictures, we should bear in mind that sometimes there is different presentation or pictures that we can see depending on the size of the lesion or whether there is any complication that has occurred. On ultrasound, it's a hyperechoic due to fat in it. It's got a lot of fat in it, so the fat will light up. And if there is hemorrhage, you can see a hypoechoic center. And in Doppler, you can get variable flow. And it's very important, as I said, to complement with other modalities, because in cases where you've got hemorrhage, there will be a hypoechoic center that then might let us to confuse it with a focal nodular hyperplasia. But I think you can all see the picture there and appreciate that we can see a mass there that is characteristic of adenoma that is not complicated by central hemorrhage. And then we'll move on to the CT scan. You can see on CT that it's usually encapsulated. The capsule is not very clear here, and then it got a peripheral feeders. It feeds from the periphery, and there is persistent enhancement in delayed phase. This one is very important because if we look at lesions that enhance in arterial phase, some like HCC, they wash out quickly. Some like a cholangiocarcinoma, they enhance, but the enhancement is delayed. And then the adenoma will enhance, but will be persistently enhanced in delayed phase as compared to hepatocellular carcinoma. So these are very important differences that will help us to critically differentiate between those lesions. And also in CT scan, if it has bled, you'll also see that you'll also see the center will be hypodense. And then you can see that in this picture, the top part is more denser than the lower part toward middle. So it might mean that the patient has bled into the lesion. And on MRI, normally we have got the T1 and the T2 phases. So you can see that it's a strong hyper-intense signal on T2. And then with the, also you can see the capsule, especially if you go towards the right side of the picture there. And in T1, it has a variable, but often is hyper-intense. So the main difference here is that it's very intense in T2. So when you do your MRI, you should be able to differentiate by using both the T1 and the T2 to be able to decide. So if you get a combination of an ultrasound, a CT scan, and MRI, you should be able to make a diagnosis of whether this is an adenoma or not. Then it will guide us on the further management of the patient and to advise them about what they should do. If they are females, you should ask them to stop using oral contraceptive pills. And then the hemangiomas. These are the most common of all liver tumors. And also, like the adenomas, they are common in females with a ratio of 5:1. And the mean age of presentation in adults is 50 years. They are equally found in both the left and the right lobes of the liver. And most of them are less than 5 centimeters. The good thing about the hemangiomas is that they have got very low risk of complications. And they can usually present with pain, but we have to differentiate to make sure that the pain is not coming from something else. They can grow as big. Like I have patients now who will be having a hemangiomas about maybe 20 centimeters or even 30 centimeters with very mild symptoms. So those patients, you watch them so that it doesn't complicate. You can only operate on them when there are complications or symptoms. Sometimes when they have trauma, they can bleed and they can profusely bleed, or they can have a consuming syndrome where they can consume all their platelets and predispose them to bleeding. So they are very nice in the sense that in most cases, you don't have to do anything. And it goes back to stress the point that these lesions, most of them, they don't need to be operated, but most importantly, we have to be able to diagnose them. With hemangiomas, the ultrasound findings, I think you know more than I do. They usually be homogeneous hypoechoic mass with acoustic enhancements and sharp margins. There's usually no vascular pattern identified, and on contrast ultrasound, there is peripheral global enhancement. This is a picture of a hemangioma that we can see. And I'm quite happy that most of my colleagues here where I'm working and elsewhere in the country that we're working with, normally when they make the diagnosis of hemangioma, even if you do a CT scan, you find that they got it right. I think the fact that it's a common lesion that we encounter makes us to be perfect at making the diagnosis. The CT scan will just augment what we have seen. This is the CT scan. This one is a very common or easy thing to diagnose with CT scan, because you can see that there's a low attenuation on non-contrasted CT, and there is peripheral and globular enhancement. This is very, very important. And once you see what you see here in the picture, you should have in your mind clearly that it looks more like it's a hemangioma. And on the CT, if you have got CT angio, you'll see kind of the fluffy appearance appearing peripherally and filling towards the center. on contrasting enhancement of the lesion on delayed. Contrasting. This is the MRI. As you can see, it's hyper intense on T2 images, as you can see, and hypo on T1. I think we are all familiar with interpreting the MRIs. It's better just to take them as a T1 and T2, simply not to go into the complex one of fat suppressed and things like that. So this is our hemangioma. Once we have made the diagnosis, patient is asymptomatic, then we advise them accordingly that they don't have to worry. If they are very concerned, you can make a follow-up and maybe repeat the imaging with ultrasound maybe after 6 months or so. The next one is FNH, focal nodular hyperplasia, is the second most common benign liver lesion after hemangioma. And also it's got female predominance. I think that most of our lesions, they have got female predominance. I think it's mainly to do with the female hormones as compared to in the males. It's a hyperplastic reaction resulting from material malformation. That's why we see the center that shows that there was an artery that was supplying the lesion during the formation of it, and then becomes an injury there, and then the effects of that will be seen on imaging. On ultrasound scan, it's a slightly hyperechoic. You can see you don't always see the central scar, but you sometimes can see the central scar with a spoke wheel-like pattern on Doppler ultrasound. I think we can see something like this on this picture. So this is something that we have to watch for. And this is the CT scan. We can see the central hypoechoic area as compared to the hyperdense area of the mass. And here you see that it has taken up the contrast comparing to the parts of the liver around it. When we don't see the central hypodense scar, we shouldn't be surprised, because this is only seen in about a third of the patients that we do. And it enhances rapidly in arterial phase and decreases in the portal phase. And usually there is no definable capsule, as we have discussed with adenoma. These are the different pictures of the MRI of the FNH. You can see that the central scar is hypointense in the picture C there, and also you see that it's hyper intense there in picture A. You can see it there, and also in picture D, comparing to the rest of the lesion. Also, the fine nodular hyperplasia as well, they are managed conservatively. Usually when you see them, you make a diagnosis, then they are managed conservatively. They only operate if there are pressure symptoms and the patient will usually present with pain. That's when then you can go in and operate. Then we have got the big one, the hepatocellular carcinoma. Now, the ones that we're discussing were the benign ones. Now, these are the malignant ones that we commonly see. This is the most common malignant. This is the most common malignant tumor of the liver, primary malignant tumor of the liver, because cancers of the liver metastasis are the most common. But for the primary cancers, this is the most common. And in most cases, it's associated with cirrhosis, liver cirrhosis. As you can see that up to 90% it arises from cirrhotic liver. That's why when patients do have a liver cirrhosis, they are followed up with ultrasound imaging to see if they develop lesions. And almost all the time when they do develop new lesions, this will most likely be HCC. It's more common in men than women, with the ratio of 9:1. So the background of the cirrhotic liver, most men, they do get cirrhosis that will be alcohol related, but there are some other causes. But generally, men will be more cirrhotic than women, or will have cases of liver cirrhosis than women. That's why it's more common in them. The most important blood test to do is the alpha fetoprotein, which helps with the diagnosis. If you do a CT scan, ultrasound CT, and do alpha fetoprotein, and we make a diagnosis of that, then it will be very easy to plan for the management of the patient going ahead. Unfortunately, we don't operate on a cirrhotic liver. So once they get this, we have to classify, look at the size and how many lesions are, and then the only treatment of choice will be a liver transplant. So this is an ultrasound picture of HCC. HCC, most importantly, especially even on CT scan, where they look also is going to depend more on the size. Sometimes the smaller size they can confuse with maybe a Haemangioma or Haemangioma, where they take contrast and diffuse. And the bigger ones also, they might also confuse with other bigger lesions like a Cholangiocarcinoma. They can be hyper intense, and in Doppler, they are seen to be hypervascular. They mainly get their blood supply from the hepatic gut. So this is one of the pictures that you can see on the CT scan, the hypervascular lesion with often irregular borders. And then the hallmark of this is venous washout. They take contrast and then they wash out quickly. I think we have seen and we are familiar with HCC lesions on CT scans. So this is the MRI. Also, it's a hypervascular lesion. It's hyper intense in T1. So on MRI, the picture that we get will be able to give us an information on whether it's a well differentiated or it's a poorly differentiated a tumor. If you can see that it's hyper intense in T2, if poorly differentiated, it's iso intense if well differentiated, but hyper intense if it's poorly differentiated. So this is a very important finding that which will add up to what we have seen on CT scan to help us classify and characterize the lesions we are seeing. And the other important thing about the liver lesions is that if a liver lesion is seen and is deemed to be operable, it's better not to biopsy it. We only biopsy liver lesions that are inoperable to prevent seedling of a tumor. The other one is the cholangiocarcinoma. Cholangiocarcinoma is classified into intrahepatic and extrahepatic. Here we are talking about the intrahepatic because we are talking about the liver lesions. It's the second most common primary liver cancer after HCC, and it's usually seen in the elderly. The most common one is at the hilar, where you have got a hilar mass with a intrahepatic duct dilatation, and it's mainly associated with primary sclerosing cholangitis. So sometimes, if you see a patient with the history of primary sclerosing cholangitis with ulcerative cholangitis, you are doing a scan on them or a CT, and you see a mass. There's something that should come in your mind is that they could be having an intrahepatic cholangiocarcinoma, which is also called a peripheral cholangiocarcinoma. These are the ultrasound findings. If you look closely there, you can see that you can see the bile ducts. Sometimes if you have a central located lesion, you can have it with bile ducts dilatation, especially of the major ducts. The intrahepatic duct, there are also different types of cholangiocarcinomas, and what you see mainly will depend on the type of the the tumor itself. But I think here we can see the ducts that it can cause. The cholangiocarcinoma, you should remember that it's cancer of the bile ducts. So if it comes, even if it's in the liver, but it originates from the bile ducts inside the liver. These are the CT scan findings. So it has got delayed enhancement. If you get a mass that when you give contrast, you can see that by the time the lesion wants to wash out, just before it washes out, that's how it takes up the contrast. And it doesn't take contrast as well as the HCC or the adenomas do. And remember, these are complemented by other investigations like blood investigation. If I said, if you have seen a lesion like this, and then you do the tumor markers like the CA19.9 in this case, and it's raised, then it goes more for a non-benign lesion as opposed to a benign lesion. This is the MRI findings. And with the cholangiocarcinoma, because it's the cancer of the bile ducts, the MRCP is very useful, and it can also help in planning for resection. Metastasis. I just put metastasis because they are very common. The most common form of hepatic malignancy is liver metastasis, and it occurs in about 95% of liver cancers. And it can come from many sides: colon, pancreas, lung, breast, and grossly they are almost always multiple. It's not always the case, but if you see multiple lesions on ultrasound or CT scan, the most likely thing is that they are metastasis as opposed to primary liver cancers. As they can be solitary, they can be confluent masses, and they can be diffusely infiltrative. So when you go to imaging, there can be difference depending on the primary tumor. In our discussion here in the presentation, I tried to look at the most common ones, took the ones from colon cancer, as colon cancer is one of the most cancers that give us liver metastasis. As I said, it depends on the primary source. Can be hyperechoic, but you can see in this picture that they are hyperechoic, and they can be a presence of spectral broadening on Doppler ultrasound. This is another picture of the CT scan of colon metastasis. You can see the complete ring enhancement is there, and one can see multiple of these lesions on CT scan. And this is the MRI showing a low intensity of the metastasis as compared to the rest of the liver. I think that is all what I wanted to share with you. If I'll communicate with Mr. Tamba. If you need references, I'll forward them to him, and then he can share them with you. Thank you very much. I hope I haven't caused much confusion, as I'm confused myself by these lesions.